Good afternoon, everyone, and I just want to say how honored I am to be included. Thank you for allowing a non-neonatologist to share some thoughts, and if it's any benefit, I am a nephrologist who loves neonates, so I will share my thoughts in this area. We'll talk about, as mentioned, neonatal biomarkers of chronic kidney disease. And what we're really talking about are the developmental origins of health and disease. And in the case of the kidney, we're harking back to the Barker hypothesis, and we're talking about structural and physiologic adaptations that prioritize short-term survival at the expense of the long-term. And it all starts with nephron endowment. How many nephrons we have to live with for the rest of our lives. In this bell curve, you see a spectrum anywhere from 200,000 to 2.7 million nephrons. The problem we have is that to this day, it still is incalculable, the individual nephron potential. So we draw conclusions lumping everybody together. And 2/3 of our nephrons are being laid down in that final third trimester. So what we know is that birth weight correlates very linearly with nephron number, which can increase up to 250,000 nephrons per kilogram of birth weight. So what I'm getting at here is, while I may specialize in congenital anomalies of the kidney and urinary tract, we're going to start talking about how premature birth, growth-restricted birth in and of itself, is a congenital anomaly of the kidney. Unfortunately, when it comes to nephron endowment, as much as we know, we are still limited by the reality that what we know is all based on autopsy study. So what you see here is taken from a beautiful publication from Maria Rodriguez, and you see that dark purple zone at the edge, that's the nephrogenic zone. That's where new glomeruli are being laid down. And you see gestation progressing across the panels. And what you see on the bottom right, we've lost that purple zone, we've lost the new nephrons being laid down. That's term, okay? So everything should finish roughly around 36 weeks of gestation. When it comes to the road to chronic kidney disease, particularly in preterm birth or growth-restricted birth, we have to accept that fetal development is in a low oxygen tension environment, and that preterm stunning is very stressful for organogenesis that was designed to take place in a low oxygen tension environment. So we have neonatal rat pups, as an example, exposed to 80% oxygen, and they have a smaller, purple, nephrogenic zone. They have smaller glomerular diameter. They have more apoptosis. And interestingly, though, they do have the same glomerular number. Now, we have to pause and recognize that our research models are not always perfect, right? Neonatal rat pups are not neonatal humans. And we have to remember that the rat model naturally does have nephrogenesis after birth, unlike us. So just keep that in mind. What we need to know further about this increased oxygen exposure, this hyperoxia stress of remaining development, is that it forces an accelerated postnatal maturation. And that is that foundation for the developmental origin of disease. Here you see dilated Bowman's capsules, you see poorly vascularized glomeruli, and this is all primarily in that outer cortex, that area of most recent development. So what we have learned from autopsy studies is that humans can, preterm humans, can have some nephrogenesis, somewhere up to 40, maybe even 60 days now suggested. However, those nephrons are not normal, even in the best case scenario. So these are the accelerated maturational changes that you're seeing here in this picture. And what we know from growth-restricted stillborn fetuses is that they show a much greater number of apoptotic cells. how we understand the impact of reduced nephron mass is really the impact on residual functional reserve. Yes, when you have fewer nephrons, that individual nephron is doing more and more, but has less and less to fall back on. That's what you see, that reduction of that yellow bar. So now what's pictured here is an adaptation of Brenner's hypothesis, where low nephron number leads to glomerular hyperfiltration, leads to glomerular hypertension, and then glomerulosclerosis. That glomerulosclerosis manifests into what we can measure, proteinuria, albuminuria, or reduced eGFR. However, that cycle just feeds itself, because as you lose glomeruli, then you have even fewer nephrons doing even more individual work. And we're focused then early on, what's happening up here in this top right corner. What's interesting to know is that a Japanese study of patients with FSGS, focal segmental glomerulosclerosis, a well-studied, often studied proteinuric disease, when they studied their population of FSGS patients, adults, they found that 37% were actually born low birth weight, whereas their local incidence is 10%. So this is trying to tie the data together for why we should care. And in addition to fewer numbers of nephrons, we also have fewer podocytes in the nephrons we do have when born preterm or growth restricted. Actually, it can be up to 33% fewer nephron counts. And what we know, not just from rat studies, but also in human autopsy studies, is that there's an increased rate of podocyte loss on top of that. So when we want to understand the impact of preterm birth, we have an example in this Swedish birth registry, 40-year follow-up, over 4 million study population. And what we see is the propensity for chronic kidney disease. Even, and this is what's remarkable, highlighted in red, in the early term. I said previously that we should be done laying down our nephrons around 36 weeks of gestation. So it isn't all about gestational age. There is a component of what we would think is otherwise good enough that has an increased association with chronic kidney disease. Then let's look at preterm birth and intrauterine growth restriction together. This is a Norwegian birth registry now, 50-year follow-up, over 2.5 million study population. And here we see the additive impact of multiple risk factors as related to birth. So here we're talking about birth weight less than the 10th percentile, birth weight for gestational age less than the 10th percentile, and preterm birth as individual risk factors. And the more of those clinical biomarkers, that's what we're talking about now. The more clinical biomarkers you have, the more predictive it is of, in this case, end-stage kidney disease, so the worst-case scenario. This is data extrapolated from the PEANUT trial, as just previously mentioned. We're looking at extreme low gestational age neonates at 2 years of age now. And we see rates of chronic kidney disease at 18%, proteinuria, specifically albuminuria, believed to come from glomerular disease at 36%, systolic and diastolic hypertension at 22% and 44% respectively. If we look out further, now this is not specifically from PEANUT, but a different study population, but same type of patient, we see higher serum cystatin C, which is another way of saying lower estimated GFR, and smaller kidneys, potentially suggestive of that reduced nephron endowment. And if we go even further, at 11 years of age, we're still talking about higher blood pressure, smaller kidneys, and lower eGFR. So what we're tasked with is how to figure out who's going to go down which road. It is projected that by 2040, the 5th most common cause of death will be kidney failure. So prematurity can increase baseline risk of chronic kidney disease by 2 to 3 times. So I'm here talking about a much larger population than what could be just a very specific congenital anomaly population. But I will hark back to my favorite crew, and we are going to learn something about biomarkers from our congenital anomaly of the kidney and urinary tract population, or CACUT. First, if we consider the overarching umbrella of all potential congenital anomalies of the kidney and urinary tract, all the way from unilateral hydronephrosis on one side to bladder outlet obstruction, for example, all the way at the other end of the spectrum. If we look at this is a retrospective analysis of just over 400 patients, single center out of Germany, and they found that a clinical biomarker predictive of chronic kidney disease, stage 2 or more, was premature birth, as we've been stating. If we now look at a more specific study population, so the solitary functioning kidney, for whatever reason, either it's unilateral renal agenesis or unilateral multicystic dysplastic kidney, for example, we have one working kidney. This is data that comes from a population just over 160, also retrospective analysis, and what it's telling us is that having an additional superimposed kidney or urinary tract anomaly, so for example, a solitary kidney with reflux, that gives you a much higher rate of the endpoint, which in this case was renal injury. Renal injury manifested as reduced function, proteinuria, or hypertension, one of the three. Neonatal serum creatinine. Now we're getting into a biochemical biomarker. There's also birth weight, less than 2,500 grams, and percentile renal length. We want to see compensatory hypertrophy. It is not good enough to have a normal-sized kidney. So these are a collection of clinical and biochemical biomarkers that are predictive of renal injury down the road. Interestingly, in this specific study, prematurity did not play out. Now let's talk about an extreme population where the possibility for chronic kidney disease is very, very high. It allows us to get more nuanced and granular data of these neonatal biomarkers, even in much smaller study populations. So we had the opportunity to study 17 babies with bladder outlet obstruction who were successfully shunted in utero. Study of this population where the endpoint was either chronic kidney disease stage 1 to 3 at 1 year of age, or 4 or worse. You can see the significant differences in peak serum creatinine during the neonatal period, during the NICU stay. You see differences in the discharge creatinine. And that is not a time-based number. That is simply when the neonatology team felt the baby was ready to go home. And there's the nadir serum creatinine. Significant differences between the two, predictive of function at 1 year. Another way of looking at that, we see absolute numbers now being more concrete, peak serum creatinine greater than or equal to 2.4, time to peak, which is interesting. In a perfect world, all our creatinines should come down. It's when they go up that we're more worried, and how long it takes them to stop going up. And that's what you see in the time to peak, just reaching almost a week. Discharge creatinine greater than 1, and cystatin C now starting to creep in as potentially an additional biochemical biomarker. You see these very distinct trends, both in serum creatinine and cystatin C between the two groups. First of all, one is going up, and the other group is going down in both over time, over that first year period. In this case, actually a year and a half sometimes. You see also different starting points. So it's not just about where we are at a year to predict where we might be at 5 and 10 years of age, but it is also very helpful to know where we started, even in the NICU. There are also anatomic biomarkers. So we have ultrasonography. We've all read reports that describe parenchymal echogenicity or cystic change, and the reality is that subjective descriptors have not been predictive of worse kidney function even at 3 years of age. However, if we start to become much more objective about ultrasound, for example, turning parenchymal echogenicity into the corticomedullary differentiation index, or actually quantitating renal parenchymal area, these different elements can predict CKD stage 5 at 5 years of age, or a serum creatinine greater than 1 at 1 year of age. And this is an example of how the freely available NIH software ImageJ can be used by anyone to estimate renal parenchymal area, and allows you to subtract out the hydronephrosis even in obstructive uropathy. So our key points for biomarkers as we currently understand them are clinical biomarkers that can predict CKD include gestational age, birth weight, and superimposed congenital anomalies. Biochemical biomarkers include neonatal serum creatinine trend, peak neonatal serum creatinine, and possibly emerging the neonatal cystatin C. And anatomic biomarkers include corticomedullary differentiation index and renal parenchymal area. But none of these traditional biomarkers distinguish the location of the kidney injury. And without that, how can we expand towards innovation in therapeutic intervention? That's where we start to understand more from our often ignored biosample, the urine. Fetal urine peptides have the potential to share with us, fetal urine peptides can predict end-stage kidney disease at 2 years of age in boys with posterior urethral valves. The 12 PUV classifier is a collection of 12 different molecules, fragments of collagen, which is very consistent with the molecular histopathology of end-stage kidney disease. And the theory here is that decreased secretion of collagen is associated with increased matrix accumulation of that collagen. There's also, now looking at neonatal urine, we know that oxidative stress in proximal tubule cells leads to upregulation of the tissue protective alpha glutathione S transferase, GST. And in the same extrapolation from the peanut study that I showed you earlier of where extreme low gestational age neonates were at 2 years of age, studying that same population, they showed an increased urinary level of alpha GST predictive of chronic kidney disease at 2 years of age. So the future is starting to show some clarity. Even machine learning can help us with our initial postnatal ultrasounds. There is now some interest in automatic segmentation of parenchyma to hydronephrosis area, and that allows a prediction model that's actually built on imaging features in 21 different PUV patients with CKD progression over almost 10 years. So it's how we start to use technology to our advantage. But when we're talking about early maturation, what I've already expressed from the very beginning is this idea of premature aging or maladaptive senescence. In the low birth weight population, as young adults, they have shown changes in DNA methylation to show advanced aging. They show an older cardiovascular profile and shorter telomere length. Anti-aging clotho has decreased expression in neonatal rats that are exposed to hyperoxia. So trying to now model the environment of preterm birth. Those rats primarily express clotho in proximal and distal tubules. And clotho is downregulated in aging and in chronic kidney disease. So in that study, exogenous administration of clotho actually increased renal perfusion and decreased vascular stiffness in those hyperoxia-exposed neonatal rats. And I know you're not shocked, to learn that diet and exercise reduce oxidative stress, reduce telomere shortening, increase your clotho concentrations, and influence your DNA methylation patterns. So current and future therapeutics, we have now angiotensin receptor blockers by reducing that glomerular hyperfiltration and proteinuria. We have SGLT2 inhibitors that paradoxically reduce your estimated GFR. And in doing so, they are lowering the metabolic stress that is experienced by transport molecules within the tubules. And in doing so, they improve the oxygenation of the renal cortex. And there's the new field of senolytics, drugs that are designed to target and increase apoptosis of senescent cells. The value here is that senescent cells have a way of spreading their problem. They get the cells nearby to become senescent. So the idea here of senolytics is that by specifically forcing those cells that are already senescent into apoptosis, they will not be able to spread their signal nearby. And this is where the idea of a hit-and-run therapy comes in, because even if the injury signal persists for senescence, it takes weeks to months for those cells to accumulate. So senolytics are being developed to be given once and maybe not again for weeks or months later, depending on the ongoing stress signal. So the idea here is creating a broader armamentarium that allows us to protect the reduced nephron endowment that we are accepting. And where do we go from here? Something very basic. Document and recognize. We need to document and spread the information fundamentally of each baby's gestational age and birth weight. And it can be very simple to miss one or two of those details, or just assume that someone born term doesn't have any other risk factors. But we really need to put all of that together in basic documentation, particularly for discharge, particularly when they leave your care. And we simply need to recognize that prematurity is a risk factor for chronic kidney disease later in life. There are screening algorithms that have been put forward for the future, things that have not been fully established in primary care, but a lot of great work in teaching outpatient physicians how to care for ex-NICU graduates comes from neonatology. So I encourage you here to spread the word that babies born under 32 weeks of gestation would benefit from screening at bare minimum of 6 months and at least every 1 to 2 years thereafter, looking for basic information, anatomic and biochemical biomarkers that we understand their predictive value and their association with renal injury long term. Thank you all very much.